Good afternoon, everyone. Thank you for joining us for this week's COVID update with Cliff Robertson, our President and CEO. Looks like we have a good group today, so thank you for attending. He will be joined by Dr. Laura Larson, who is the head of our OB Hospitalist program, current Chief of Staff for St. Francis Hospital, and one of our beloved obstetricians gynecologists on staff here. So we will start with Dr. Robertson for his quick system update.
Thank you, Lauren. And Savannah, if you just bring up the slide. So as per my usual, I wanted to just share some of our data with all of you. As you can see, we are continuing to experience this very welcomed trend in terms of the number of COVID inpatients continuing to decline week over week. So that is obviously great news. It's great news for us here at St. Francis Health System, but more importantly, it's great news for folks in the community because we do seem to be seeing fewer cases and for sure fewer cases that end up in our hospital. This again is a slide that just compares the same calendar date, 2021 versus 2020. So the blue line was a year ago at this time. And while the lines haven't yet completely converged, obviously the trends are, the current trend is in the right direction, the correct direction to get us back to where we were in terms of the number of inpatients this time last year. This is the other graph that I share. This is the number of folks that are requiring a mechanical ventilatory support. You can see the blue line, which was March of 2021, the third month of our surge that occurred over the end of the holidays and into January, compared to where we are in October. We continue to still see a fair number of folks that are younger in age that are requiring mechanical ventilation and unfortunately are requiring support for increasingly long periods of time. And this is the dashboard that also is on our intranet, which shows you just where we are today in terms of the total number of patients. One thing I'll point out again, the number of COVID patients is 152, but the number of inpatients, so these are folks in the hospital that are still in isolation, which is another way of thinking about they are still contagious from a COVID perspective. That number is about half. So what that says to you all is that we have a substantial number of folks that have been in the hospital for more than a week, more than 10 days. They are no longer a risk of shedding COVID and infecting anybody else, so that they're not required to be in isolation, but they are still too sick to be discharged and sent home. And then the last is on the bottom, just the age of the patients on ventilators, as you'll see, continues to be young from my perspective. 53 is our average age as of today. The next slide just again reinforces the total number of vaccine doses that St. Francis Health System has administered in the community. And so we're sneaking up on 100,000 doses of vaccine. I think that's it for me, and it's my pleasure to turn it over to Dr. Laura Larson, and she'll make some comments to talk to you a little bit about the data that is out there around pregnancy and vaccines and COVID, and then we'll take whatever questions you might have. Go ahead, Dr. Larson.
Yes, thank you, Dr. Robertson. I appreciate having the opportunity to speak to you all today. I am an obstetrician gynecologist who's been with the St. Francis Health System for over 10 years now. And I work as a hospitalist in obstetrics and gynecology. And our group has been very involved with caring for the COVID positive pregnant patients from the beginning of the pandemic. As you know, COVID in the early days took a while to take off in the Midwest, while New York and Washington were having their initial surges. We had time to watch their experience and learn from them. And we had a number of pregnant patients who were positive, most of whom had mild infections. However, some of them even then ended up on ventilators and had early deliveries. In the Delta surge, the second surge that Dr. Robertson showed on the graph, the patients have been younger and sicker. There are more children admitted to the Children's Hospital, and more pregnant patients have been sick from COVID rather than just testing positive with asymptomatic or mild infections. And in that period of time, this 18 months, a lot of things have happened with the research into COVID and the rollout of the vaccines, which started in December of 2020, just 9 months after the first cases in the United States. And vaccines got off to a relatively good start in some populations, and we have seen a lot of vaccine hesitancy and caution in our population for a number of reasons. One of the reasons in our pregnant population is that they did not feel there was enough research, enough understanding of what the vaccines could do in fertility, in early pregnancy, in late pregnancy. And one of the programs that the CDC started with the vaccine rollout is called VSafe. And VSafe is a vaccine safety and effectiveness survey that patients who receive the vaccine can sign up to receive surveys by text once a week after their vaccines, then once a month, and finally at 6 months and 12 months to determine whether they had symptoms. And also a question on each one of those surveys was whether the patient had a positive pregnancy test. And just early in April, there was a report of the initial 800 pregnancies that had been exposed to the COVID vaccine. And the numbers were really good. They compared the miscarriage rates, the preterm delivery rates, and the babies that were growth delayed or small for their gestational age. And those numbers were very comparable to the numbers in the general research that's available in pregnancy, about pregnancy. So the vaccine did not appear to be increasing the risk of miscarriage, the risk of preterm delivery, or fetal effects. Now with VSafe, they have over 160,000 patients who have been vaccinated and have had a pregnancy occur either before or during their vaccine course. And they have enrolled more than 5,000 in an ongoing survey to see what happens with their pregnancies. And that data as well is beginning to roll out and will be very interesting over the years. Now, on the other side, what about COVID in pregnancy? What do we know now that we've had 18 months of exposure? There have been 171 maternal deaths in the United States from COVID in pregnant women. That may not sound like a large number when we're talking about 700,000 people across the United States, but that's 171 pregnant women who became sick enough that they passed away, and often their babies did as well. The ones that had the babies that survived are now motherless as a result of COVID. In that period of time, oh, I'm going blank. Sorry about that. There have been about 127,000 reported cases of COVID in pregnancy. And of those patients, 22,000 have been hospitalized, about 1 in 5 of the pregnant women. And of those patients, the risk, if they become hospitalized, of having to go to the intensive care unit for care is about 12%. The risk of being on a ventilator or a tube in the airway to breathe with is about 9%. And the risk of having to go on ECMO, extracorporeal membrane oxygenation, to breathe for the lungs while they're recovering is also about 9%. And that is 11 or 12,000 women in the United States who have had to have that prolonged intensive care during pregnancy. So overall, what we have found in our data, and these numbers were just released last week from the CDC, 97% of the pregnant people admitted to the hospital with COVID were unvaccinated. So 3% of the people admitted with COVID, symptomatic enough to be in the hospital, had been vaccinated. But if you take the fact that only about 30% of the pregnant patients at this time in the United States have been vaccinated, and yet they only represent 3% of the hospitalizations, you can see that the vaccine is effective in reducing those risks. Overall, a woman with COVID in pregnancy is 3 times more likely to go to the ICU than a non-pregnant person of the same age and health status, 2 to 3 times more likely to require advanced life support or a ventilator. And there's a small increase in the risk of dying, which is a blessing. However, the prolonged hospitalization also causes long-term difficulties with their recuperation, many of them going home on oxygen and taking a long time to get back to their normal lives. They have also seen in those hospitalized patients a risk, as we talked about, of having to deliver 2 to 3 months before the due date, when the baby is not at all ready yet. And we have also seen an increase in stillbirths or babies that pass away during the pregnancy due to COVID, as well as preterm birth outside of those admissions to the hospital, which have a clear increase in the risk. So the CDC came out at the end of September, just in the last 2 weeks, with an urgent health advisory to recommend the COVID vaccine in pregnancy. They have looked at the fertility data and have clearly said that all the concerns about fertility rates with the vaccine are misinformation. We are not seeing that. And the benefits to avoiding hospitalization, avoiding those preterm births, avoiding long-term or long-haul COVID, which can be more than 10% of even those young, healthy people who have what they call mild illnesses. This is still a dangerous disease. And if you have a question about getting a vaccination now, when we seem to be on the downslope from the Delta variant, my answer to you would be, we're not out of the woods yet. There are still a number of cases in the community. I have patients coming in every day with new onset infections and have been seeing COVID patients the entire time, that 18 months in our labor and delivery unit. And we don't know what's coming, what variants will be significant, but we can say that all the data that we have shows that the vaccine is safe and effective and can keep a pregnant woman out of the hospital and protect her baby from early birth or stillbirth. I think those benefits are very clear. And I am happy to say that the American College of Obstetricians and Gynecologists, which helps us as our national organization to practice evidence-based medicine based on the latest and best data on best practices, and the Society for Maternal Fetal Medicine both began to talk about the benefits of vaccination as early as June and July of this year. They didn't jump right in and say, just get the vaccine. They said, let's look at those initial few months and the VSafe data from the CDC. And it's becoming more and more clear the vaccines are safe and effective. And I have seen a number of patients who were very, very ill from COVID and worried about their babies and worried about their families. And if we can prevent that occurrence, then the science is doing what it should to help humanity. So I think I would have loved to answer some questions if anyone has anything that they'd like to know.
Ditto to what Dr. Larson just said. We would love to open this up for questions from the group for either of our presenters today.
Wow, we must have given the perfect presentations. We said everything they needed to know. That
You're very thorough, Dr. Larson. One thing that we were talking about before the call was why it took so long to get this information out about pregnant women and vaccines. I thought your answer was great. That might be something to share.
This was addressed very clearly in that Washington Post article from last week, and they went back in time to thalidomide back in the 1950s or 60s was touted as a medication that was very safe. It was very popular in Europe as a anxiety agent, relaxing agent, and helping with anxiety and sleep. Unfortunately, as it rolled out to a wider population and pregnant women were taking it, particularly in the first trimester, there was a serious birth defect that occurred with shortening of the arms and legs of the baby, severe shortening, where their arms were almost non-existent. And that began the concern about exposures of medications and vaccines and anything you put in the human body. It also allowed us to have a healthy respect for the ill effects of exposures to smoking and alcohol and medications. And all of those issues should be discussed with a physician when a patient begins her prenatal care, or even prenatally before they become pregnant, to have a chance to optimize their health. So during those years, the risk of including pregnant women in clinical trials was considered too much danger, too much litigation risk. So they were kept out because they didn't want to have another thalidomide experience. However, we have approved vaccines in pregnancy for a number of different conditions, including influenza, which has been recommended by the American College of Obstetricians and Gynecologists for over 15 years. Before, it was just in pregnant patients that have risk factors like asthma or allergies or heart disease, but now it is recommended for every pregnant woman. And we also give vaccinations for measles, I'm sorry, not measles, the Tdap, tetanus, diphtheria, and pertussis during the pregnancy, so that the mother is immune when she has a small child in the house and does not transmit pertussis or whooping cough to her child. So as we have gathered this information about the safety of vaccines, we have gotten a broader range of things that are considered safe in pregnancy. And certainly the benefit of being able to prevent COVID made this something we wanted to study. And we obtained some early information and began to roll it out. But all of those national organizations were cautious, looked to see what the initial data was. There were no ill effects, and they were careful, and they should do their due diligence. But on the other hand, this is a national, worldwide pandemic, and you have to be able to get as much information as possible and yet save those lives too. So that's why there was a bit of a delay with pregnant women, but now we have all of our national organizations on board saying, please get vaccinated, and advising us to talk to each and every woman about vaccination.
Thank you. We have a question from Matt Trotter from KWGS. Can Dr. Larson speak to whether her patients appear to have a vaccination rate at, above, or below the 30% that you previously mentioned?
Well, I am not the best one to speak about that because I work in the hospital where most of my patients are unassigned. And I also see patients who come in for problems with their pregnancies to a triage area. And among those patients who have good prenatal care, yes, I'd say it's about 1 in 3 or 4 now. And I think the Delta variant really increased the number of people who are pregnant who are getting vaccinated because they're beginning to know more of their friends or more of people in their community who have had serious outcomes. So I'm beginning to see that. However, in the population I serve, most of them have not seen physicians, have not been exposed, and we are trying to get them all aware that the vaccines are available for them now.
And then another one in our direct messages, does the mRNA vaccine have the ability to affect the baby's DNA?
Oh, I love that question. Thank you so much. mRNA vaccines were actually, they started to study them back in the 1980s or 90s, I believe, when they were doing research initially on Ebola and HIV. And the vaccines did not work in those populations because of the rapid mutation that was going on in those particular viruses. However, the mRNA vaccine was studied very deeply, and what it does is it's a little piece of genetic messenger RNA, not DNA. The messenger RNA goes into the cell and takes over some of the machinery to create the protein that the coronavirus has on its outer core, the spike, those little spikes in the corona that you see in the drawings and electron micrographs. So the immune system sees that spike protein being produced and creates an immune response, an antibody to that spike protein. Subsequent studies within weeks are not showing that the mRNA is even there anymore. It is broken down in the cell, but that creation of the protein, which does not appear to have any other effects in the body or in the cell individually, has allowed the immune system to create a memory and be able to respond when the spike protein is in the neighborhood. So mRNA is really the perfect kind of vaccine in pregnant women because it does not change the mother's DNA and it does not stay in those cells long enough to go to the baby. However, babies are being born to vaccinated mothers with measurable antibody levels, the immune response, just as if they had received an antibody infusion like Regeneron that are being given in infusions to sick adults. And they're seeing that same antibody in breast milk. So the mother is vaccinated and is able to provide her newborn with a level of immunity both through her placental donations to the baby, as well as to the breast milk after the baby is born, which is brilliant.
That was my next question, was about breastfeeding. So thank you for asking that one, or answering that one. Is there any information about booster shots for pregnant women?
There is some information on booster shots. They have not extended, we go through several steps in the approval process, and the ACIP, the association, it's the counseling organization for immunization practices, initially wanted to just give boosters to the immunocompromised. However, the CDC said from their data that they wanted to provide boosters to people over 65, and they also extended it to healthcare professionals who are frontline workers exposed to COVID on a daily basis, and to school teachers. And we have not included pregnant women as of yet, but I can see that coming soon, because they are in that population that are immunosuppressed to a point, because pregnancy is a condition that reduces your immunity so that you don't attack the baby and the placenta as foreign tissue or as invaders. So we don't have clear-cut advice to give boosters to the pregnant people as of yet, but I can see that in the near future it will be happening. Those recommendations for the booster also are 6 months after the second shot or 8 months after the second shot, and a number of people who were young and healthy as the vaccines rolled out did not receive their vaccines until April, May, June. So they would just be due for a booster at the end of the year. So I suspect that we'll have more information on boosters being provided to them at that time.
And then here's another interesting one. Are there any unique COVID symptoms experienced by pregnant women?
I would say from my experience dealing with patients that there is not. However, because they have that more rapid breathing and less pulmonary reserve because of the baby and the intestines pushing up against the chest and the lungs, they have more shortness of breath earlier in their course than a non-pregnant person of the same age. So it is more marked because they're already a little bit more rapid breathers and air hungry at some times. So a pregnant woman will talk to you and then stop and get a breath because she doesn't quite have enough air to get all the way through a long sentence. So we see that very dramatically. I have not seen as much of the loss of taste and smell, although it is certainly present. And it seems that we see more nausea and vomiting in our pregnant patients that test positive for COVID. And part of that is because the intestinal tract of a pregnant woman is often more sensitive to illness, and so that may be why we're seeing that, along with dehydration in those patients, that they might not have had it if they weren't pregnant.
And then I just got a text message that you mentioned earlier, unassigned patients. You might explain what that means and how OB hospitalist works.
Oh, unassigned patients?
Yes.
Okay. I said when I first took this job that my job was to provide safety in labor and delivery. I am in the labor and delivery unit to take care of the mothers who are having babies whose doctors can't make it to the hospital fast enough. And that's part of my job. It is also to be able to be present and take care of those patients who come into the hospital who have not established care with a physician. Sometimes they're just at the wrong hospital. They have someone across town that they see, or in another state if they're visiting. But there are a number of people who do not make arrangements to have prenatal care for many, many reasons. And when they come to the hospital, there is a team of people, including the OB hospitalists and the OSU OBGYN residents that are available to take care of them 24/7.
Thank you. Any other questions from the group or anything that Dr. Larson or Dr. Robertson would like to add? Well, great. Well, thank you again for participating in this. If anyone has suggestions or questions or recommendations for future weekly update topics, please get them to myself or Siobhan, and we'll be sure to incorporate those into future availability. Thank you, Dr. Larson. Great information. And thank you, Cliff, as always, for being our great moderator and host.
Well, thank you for giving me the opportunity to speak. I really appreciate this.
Absolutely. Thank you. Bye, everyone.
Bye-bye.